Welcome to the Next Level Human podcast. As a human, you have a job to do. In fact, you have 4 jobs: to earn and manage money, to attain and maintain health and fitness, to build and sustain personal relationships, to find meaning and make a difference. None of these jobs are taught in school, and that is what this podcast is designed to do: to educate us all on living our most fulfilled lives through the mastery of these 4 jobs. I'm your host, Dr. Jade Teta, and I believe we are here living this life for 3 reasons and 3 reasons only: to learn, to teach, and to love. In this podcast, I will be learning, teaching, and loving right along with you. I'm grateful to have your company. Here's to our next level. What's going on, everybody? Welcome to today's show. I am back with Joe Miller. You may have known I did a podcast and an interview with Joe for Evolve a couple weeks back, and we are reconnecting here on my show to talk about the Evolve process, and specifically regarding testosterone replacement therapy for men, but really just getting a sense of what it's like to be involved with Evolve, what it's like from the patient perspective. Joe Miller, welcome back. Thanks so much, man, for hanging out with me.
Yeah, no, appreciate it. It's great to be back on together and chat. I know we had a great collaboration last time. We kind of had a quick list of bullet points and just ran with it and went through everything. So yeah, happy to be here. It's definitely a topic I'm really passionate about. Just it started being a male who's in his 40s and have young kids and wanting to stay athletic and fit. It kind of started for me from that standpoint. I have a pretty extensive background in kinesiology and pharmacology, and just kind of became a patient first and saw the benefits and just kind of fell in love with the topic. So it just made sense to kind of, find an organization like Evolve that does the process the way they do things. And then, as you're doing those things, I'm sure like you start to see the other side of it, which is, the female hormones and, looking at my wife or other family members and things like that. I have 2 young daughters who are not at that point, won't be at that point for a long time, thankfully for me, where they have any kind of obstacles with that. But it's just kind of really interesting how there's so many similarities and some differences between both. And so that's really just been a passion of mine. And it's pretty exciting to have the opportunity to talk to people like yourself and just work in this industry as a whole.
Yeah, I love what you guys are doing. And I think it's one of these things that a lot of people are wanting and needing, because it is very difficult oftentimes to move into this arena with your primary care physician. They don't always understand this stuff. They don't always have the time to work with you in the way that I think it should be done. That's one of the reasons why I've really loved Evolve. But let's talk about this idea just for a minute, starting from the beginning. What data do you all have, or how are you seeing in terms of the clients coming to you? We oftentimes think of individuals with hormone issues as being older, right? Like I'm 48, you're in your 40s. Typically that's the age range. But one of the things I've noticed is much younger men and much younger women beginning to show signs of hormone imbalances, if not outright deficiencies. And I'm wondering, what is your thought on what's going on there? And more importantly, is that what you're seeing at Evolve as well? Or is this just something that I'm seeing, sort of in my clinical, sort of experience?
Yeah, it's interesting you say that. It's definitely something that's been changing. I think there's a lot of good content out there now that are making we're talking specifically with males, like making them aware of what the signs and symptoms of like low testosterone are. And I think that's causing them to ask more questions and investigate more at different ages, because, historically it's been, 45 and up is probably when you want to take a look at these things. And now, you're starting to see younger and younger men have some of these issues and symptoms and coming in to get treatment or to see kind of what's going on. And, one of the best practices I heard out there that's recommended is, try to just get, your routine blood work, even if you can't get it from hormone blood work, that is, if you can't get it from your primary care physician, finding a place, obviously like Evolve, somewhere that can give you a hormone panel, maybe at 20, 30, 35, 40, 45. So that you know like what your normal is. And I think that's kind of checkpoint one, is just encouraging people to get tested, because even if you are feeling good, I'd still feel there's a lot of benefit to have that information when you're younger. You may have to shell out a little bit out of pocket to get that, but it's going to just give you loads of information that I wish I had, 10, 20 years later. That being said, we are seeing more and more people come in, with symptoms of low T. They're fatigued, depressed, issues with sleep. Their kind of body composition's changed quite a bit, and really activity and eating didn't change as much. ED issues, libido issues, things of that nature. And they just don't have, talk about not having that same drive. And so there certainly are in traditional medicine a place for those things to treat them. And I think, one of the things we found is for some of them, that's definitely needed. Like if you take some of the different mental issues that are out there, there's definitely a place for that, and some need that. But I think sometimes too, talking about a primary care or trying to get someone some instant relief, they may be diagnosed with depression, but when you look at, well, what's causing the depression, maybe low testosterone, those type of things, in regards to just why is it like that? I mean, I think there's a combination of things, there's a lot of discussion. There's multiple different studies out there on this. And I think it's going to be a hot topic for the next 10, 15 years, as this is a growing industry. I think I've seen a study where it was up, I want to say fourfold 3 years ago. Testosterone prescriptions are up fourfold. And I know that trends continued across the US. And I think there is something to be said, and this is probably, again, more in your wheelhouse. If you look at lifestyle management earlier, especially for men, is if you think about it, and maybe I'm a little biased being a man, but I think, for women, it's almost like an over-indexed on body composition and health, where they're really hard on themselves, and society's pretty tough on them. Men, like, we get a little gut, got the chest, drooping a little bit, whatever. It's just kind of like, yeah, I'm just a man, it's like, no, like, you got to take care of that, my friend. We got to stay on top of this stuff, right? We get the shirts and the clothing that can hide it now, and you can go on social media and it's like the shirt's tapered this way, right? And I'm not, criticizing them for their body composition, more from a health perspective. Is just, I think generally as a population, we're more sedentary than we were. If you just look at all the advancements in technology, which are wonderful, but if we're not counting that one with like an active lifestyle, number one. And then I think there's some other things out there that are affecting that, if it's environmental toxins as well as food quality. And the nice thing about, Evolve and some of the services that are starting to come on the forefront in the industry now is you can test all this stuff. You can test, toxins, you can test micro and macronutrients. A lot of people underestimate even the micronutrients and how they work in the process of making these hormones. And if you're really, really low on those or deficient for long periods of time, how that can be fixed. So there's some natural and lifestyle things, I think, that are affecting that. And obviously then there's times where there's just is an issue. If there was some kind of trauma or change in that person's endocrine system where they just have to have treatment, or there's other times where maybe they just need a little spark to their signaling, and that could help. So pretty wide range there. But I think, again, it's just the general message is, hey, test, assess everything first before you kind of go out and explore on your own.
Yeah, I'm going to second that. I think if I could have gone back and gotten my, numbers in my 20s, that would have been fantastic. And it's really interesting too, because I've had my numbers checked multiple times now. I pretty much do mine yearly. And my father, he's 80 now, but 5 years ago, I know, because we both got our testosterone levels checked, and his were higher than mine at 75. And I was 45 at the time. And it kind of blew my mind, when you think about that from a perspective. And I also share with everybody here, which I think I've shared with you too, Joe, is that when I was deep in practice in Santa Monica, California, 5-6 years ago, most of the people that I was really seeing low testosterone levels on were men in their early 30s, 30 to 35. That was who I was writing most of the scripts for. And it brought up this whole idea, which we can get into, of that not wanting to give them the traditional TRT, because most of them were still wanting to get pregnant and have children. So they still wanted to father children. I would second what you said, though. I think a lot of it has to do with stress. And not that, when we think about stress, certainly hunter-gatherer societies were incredibly in an incredible amount of stress, but they also had a lot of downtime and recovery. They also arguably had more nutritious food. So when you combine excess stress with less nutritious food, less sunlight. That's another thing that I think the conventional medical world has sort of gotten wrong. Telling everyone to stay out of the sun. We know that vitamin D is intimately connected to testosterone levels, and then of course the estrogen exposure through persistent organic pollutants in our environments. That's what I would say is probably one of the bigger things that is going on here. And then I'm interested what you say about this too, because one of the things I saw in my clinical practice, I'm no longer in clinical practice, but one of the things that I saw was soon as intermittent fasting came along, the keto diet, some of these very low carbohydrate diets, you started to see testosterone levels fall in some of these people, at least in my limited clinical experience. We have to be careful about that, right? Like one clinician's experience doesn't necessarily translate over into what is happening in the world. But one of the things that I noticed is that hardcore, long-term keto dieters, low carbers, things like that, were having issues, which brings it back to kind of what you said, macro and micronutrition. These reproductive hormones are incredibly sensitive to the micro and macronutrition. Low calories, either from low fat, low protein, or low carb, are probably a cause. And so people who are dealing with this may want to look at these macronutrient ratios, and specifically the micronutrients. The big ones that come to mind for me are zinc, magnesium, vitamin D. Those are sort of the big ones that, sort of show up. And there is research suggesting that if you're low in those, deficient in those, and you replete, you can see testosterone levels go up. And I have seen that in my clinic as well. But again, to your point, not a lot of people are testing this. And it sounds like at Evolve, we have the ability to do that. So I'll just sort of get your thoughts. And then I want to kind of go into the next thing of how do you push towards the testing? So is it, okay, if you're low, T, do you go in and look or suggest people are looking at these micronutrient issues, and how are you testing them? Yeah. I'm curious.
Yeah, sure. I think to take the micronutrients is to first, and then kind of walk through up to testing. I think it's really interesting. I think I want to say it was around 1920s or somewhere around there. The ability to track what vitamin D actually does, like its functions, they didn't have it, and so they just vitamin D, right? It's called a vitamin, and today what many have said in the field is the way it acts is like hormone D. It actually works as a hormone in the body, is how it as far as the processes it does. So I think a lot of people underestimate the power of some of those micronutrients, to your point. And when think of it this way, like the easiest way I can explain to anyone is we have, two main things that we're trying to do as humans, right? We're trying to survive and reproduce. Well, if you're deficient in a bunch of micro and macronutrients, or for a prolonged period of time, extremely, low on your calories, if your body has to choose between survival and reproducing, which one's going to go away first, right? It's going to be reproduction. So it's going to start to down-regulate some of those hormones, because it's saying, we don't need these. Like, I'm trying to live here, right? Like, I don't need to reproduce right now. I need to stay alive. And then maybe later we can revisit this idea of reproduction, right? So our bodies are really smart by nature, and how they can adjust and make those moves. So I think that being said, lowering your body composition certainly has a lot of benefits. You have to do that through a variety of different methods that are out there. But I think it's just, I think to your point is what you're talking about, when it's a prolonged period of time, that's when it gets problematic. If you want to work on your insulin sensitivity or do some kind of aggressive behavioral change to kind of jumpstart things, that's okay. But just work with a professional to monitor blood work, to monitor progress, and then to either titrate your calories back up or bring those micronutrients back in. Don't just see a few posts online and then cut out a whole food group and just, demonize it and then think that that's going to solve everything, because there's going to be some cascading effects down there that are going to work against you. Again, the benefits of fat loss are going to help, but that's where you might find yourself kind of stuck in a rut as you come out the tail end of it. And, so at some point, I'm sure you're going to want to, bring your calories slightly back up to meet some of your energy demands. So I think that's a more kind of what's happening at like an overview level within our bodies with in regard to hormone and diet and making those changes. But I think the key there is, as you were getting to kind of testing is, when someone comes in, we can assess, taking a look at, if you look at just from a blood work standpoint and hormones, Is it their signaling hormones that are not signaling? Like, are they just not firing? They're not sending the signals in the body to create the testosterone and kind of get things going. That's one pathway that could be off. Is it the ability for all that testosterone we have is just way too bound up? And so we're actually producing enough, but we have total and free, and that free is too bound. And so maybe before we jump on TRT, let's try to do some different protocols to maybe release some of that binding and see how you feel and reassess. Because that's the other part is you could do TRT for the next 40, 50 years and feel amazing, but you're going to, when you start, you're going to need to stay on that. If once you're replacing, if you want to stay at that same level, the way you're feeling in the majority of cases. So for younger guys, is there a way we can take a look at all those lifestyle changes we talked about earlier, and then take a look at, can we get the signaling to return on through some different protocols and methods just to work on your signaling? See, does that improve? Again, if it's a binding issue, see, can we do some things through your treatment and through some lifestyle modifications to help free up some of your free testosterone, that's the active stuff. A lot less of that is actually needed to make an impact. I'll just give you one quick side example. Myself and a friend of mine, he had close to double the total testosterone as I had, and had exactly the same symptoms of when I started treatment. And I was just blown away. I literally just, being early on in it, I was like, are you like, really? Are you sure you're just not, you just don't want to get on testosterone for the novel idea of getting on testosterone? Well, as I dug into it more and worked with the physician, it was looking at the fact that so much of it was so bound up that really the good stuff, the stuff that's active, just wasn't there. And so that was kind of the first step, was how do we get some stuff unbound? Because if we would have given him more TRT and just overloaded his system, when all those other cascading effects that happen between estradiol going up and different strains in the body that are just unnecessary. And so I think it's really interesting. You can look at some of those, those different mechanisms, actions, and work from there. And it doesn't hurt to start, and when you do start, or if you do have to start, to retest. Because maybe you start at a smaller dosage to kind of find your sweet spot as you're going through treatment. And so there's a lot of different things there in that respective. The other we talked about was nutrition. There are some different nutrition panels that we have access to. So one of the things is just there's multiple, vetting out multiple different respected testing companies, diagnostic processes in the industry, and bringing them in so that we can kind of pick from which ones we feel is going to best fit that patient. And internally providing a ton of education on that, so our team knows which ones to recommend based on the symptoms, what's going to give that patient the best results. Because that way we can say, let's pause here. Like a lot of companies out there, I'm sure they have the best of intentions. They'll just, hey, come on in, you're low, here's your testosterone, right? Again, I think they have the best of intentions, but in that case, what if, we checked some things on some of their nutrition panels, took a look at some of those toxins we were talking about earlier and things, and just saw, if we can change those, maybe we feel better. And we're not talking like come back in a year, right? Let's change some of these and monitor 4, 6, 8 weeks. Let's see if we see some move here. And then maybe we can fix the problem that way and see in 10 years for TRT, right? And go through that process. Or maybe, hey, we didn't really find much. We're still going to address some things that we learned from this assessment to make your overall health better. You're going to feel better, but it's still not going to be where you want to be. Totally get it. Now we can talk about, TRT as that replacement there. As far as for those younger guys, another thing just to consider with that, as you brought up earlier, was if they're younger and they're not really sure about reproduction in kids, there are some risks there that, the longer you're on, and if you're shutting down your natural production and the effects that could have on sperm count or just fertility in the future, there are different signaling treatments that we have that just basically is telling the body to release testosterone. It's the same natural signal that's already there, and we're just mimicking that, and that will increase testosterone. And then to see, does that cause enough relief in symptoms where you feel good and you're like, I could just continue with this treatment. And you kind of go through a sequence depending on your body and how it metabolizes that treatment protocol. There's different, phases that you can roll into over time and just do those treatments on and off and see if that goes. Could be one option. Another option could be maybe that signaling just kind of woke everything back up, and maybe you can go a little longer in that natural signaling staying on. And then, hey, I'm going to check in 3 months or 6 months and get my labs again, just to make sure that signaling stayed on. And that's not going to affect their fertility in any way. So there's a lot of different options there. And I think if you are investigating this more, just take ownership of your own health like you are by reaching out to somebody. But then once you're talking to those people, those experts, just making sure you do due diligence to see what is the plan and why. What's the why behind this? And are there some steps I can take before I'm, locked into this one streamlined process? Because if there are, not that that process is bad if it's needed, just making sure like what's the best first step to take in this process.
Yeah, I love this, Joe. And I love how you kind of broke that down. And I'm just going to repeat some things for the listeners here and just tell me if I'm getting it right. One of the things that, Joe is pointing us towards, first of all, which I think is very important and very different for a company who does this, right, is that if you listen to what Joe's saying, he's very careful about let's get the testing done. Let's take a good history and let's make sure that this indeed is someone who's going to benefit most from replacement therapy. And part of, if you're listening to what Joe's saying there, part of what he's doing is he's looking at things, not just total and free testosterone, but things like SHBG, things like high sensitivity estradiol, things that are important to understand what is going on. Because SHBG, in case for those who aren't as schooled in this is the thing that can bind up, this and albumin and other proteins can bind up testosterone. If testosterone is bound, as Joe was telling us, it can't really do its job. And so it's very important that you have someone who can read all of these numbers, get the right metrics, and then look and say, okay, what is going on here? A clinical pearl I can give everybody here is that thyroid hormone has an impact on SHBG. And if thyroid hormone is not adequate, and this was an issue with me actually, with my own testosterone issues, you can have SHBG go up too high. It can begin binding testosterone. You think it's a testosterone issue. It's actually a thyroid issue. And oftentimes I've seen with men that I'm working with that I am tweaking both thyroid and testosterone. Now, Evolve would be catching this. And this is what's really important about the Evolve process that I want to educate you all on. They're doing testing in a way that is more holistic, not to mention they're not just jumping on testosterone replacement therapy right away. They are saying, okay, there is some indication of maybe some micro nutrient issues here. Let's go and look for that. And I thought it was really interesting, Joe, coming from a company that sells testosterone replacement therapy and hormone replacement therapy, that you all are essentially going, no, we're not just going to give people hormone replacement therapy. This is a very important thing when we're doing functional medicine, to look for the causes. And I love that you all are doing that. And I do want to point out one more thing, just so people aren't missing this and make sure I'm getting it correctly. One of the things Joe was educating all of us on was this idea that when you get on testosterone replacement therapy in the traditional sense, if you do go on an injectable form or a patch or something like that and get this testosterone in your system, it can shut down and will over time, especially in higher amounts, shut down your own testosterone production and the other sort of issues that go on in the testicles, which is sperm production. And so if you're a younger man, one of the things that bodybuilders used to do, where they would just use high dose testosterone therapy as a form of male contraceptive. So this can shut down sperm volume enough that it can impact infertility. And so it sounds like what you're saying, Joe, is you're moving in those cases to things like perhaps Clomid or HCG that are looking at, dealing with the signaling of FSH and LH to sort of turn on both testosterone production and sperm production, whereas just TRT will definitely ramp up the testosterone because you're getting it exogenously or from an outside source, but it can definitely shut down the production of sperm. And so we have these other things like Clomid and like HCG that act as, one is a selective estrogen receptor modulator, that's Clomid. The other one is basically acts a lot like luteinizing hormone in the body, HCG. And these can turn on the production of testosterone and sperm. So for you men listening to this, if you're talking to a physician and you've been looking at Clomid versus HCG versus TRT, this was what Joe was sort of talking to us about here. So there are really three different options. And actually, one of the interesting things, Joe, is that I have seen you can use Clomid and HCG to see if the hypothalamus pituitary connection to the testicles are actually firing correctly. And so sometimes when there's non-responders to those, it can point to, oh, this is coming from the HP axis, the HPG axis, hypothalamus, pituitary, gonadal. So the hypothalamus has to communicate with the pituitary, which has to communicate with the gonads, and those drugs can point to an issue there. So I don't know if there's anything else that I got wrong there or that you want to educate us on, but I just wanted to walk them through that so they understood sort of the options here with Evolve.
Yeah, and there's a couple other treatments that we have as well. One that's really common to HGG. The regulations have increased quite a bit in the industry recently. It certainly did what it needed to do based on how you describe it. But we also have another one called Kisspeptin 10. It basically mimics kind of what happens in puberty for testosterone, and same concept as far as the signaling to see, can we wake it up or can we just turn this on to get things going? A couple other things that you mentioned there too about SHBG. I think one thing a lot, mainly if we're, speaking specifically about men, is we forget, on both sides, how estrogen works related to body composition. And as you mentioned, environmental toxins increasing our estrogen. So SHBG does not just go up, because of higher levels of testosterone to bind to that testosterone. If estrogen is elevated in a man's body or a woman's body, SHBG will also go up as well. So a lot of times you'll see by changing body composition, that can help lower that SHBG, free up some free T, and that can also help improve someone's overall health. So I always recommend, like, your minimum standard of care, generally you're going to have, 2 or 3 tests in a year, essentially, if someone's on autopilot with their treatment. But if you're starting treatment because, specifically TRT, because you're overweight, you don't have the energy or drive to lose the weight, and you're using that to jumpstart your plan to kind of do some healthy activity, and then your body comp changes pretty dramatically. Let's say it's 6 months or 9 months later, like retesting to see where that SHBG is, where your estrogen is, because as we know, the higher our body composition is, the higher that aromatase enzyme is, which basically will kind of grab that and convert the things we're trying to turn into testosterone into estrogen, as well as, now that estrogen's higher, that SHBG is higher, which is also binding the testosterone. So it's kind of like this really mean trick our bodies are playing on us inside there. And our body fat just keeps getting higher and higher and higher. And, you can look up or go through like metabolic syndrome. Like, it's like the meanest thing our body does, where one part's done. And then it's like, you would think, well, oh, my body's got so much body fat on it. It's warm. It's got enough, energy in there. So it's going to just stop packing it on. Well, no, this is like the train is going off the tracks here. Like, first it's that, and, your blood sugar levels, your thyroid's affected, and it just keeps compounding. And so I think, on the one hand, it's definitely alarming for people to see so many young males engaging in this and finding that they have low T on the one hand. On the other hand, though, I think it is good that they're taking a more proactive approach to their health, and hopefully can reverse that. And then, if that means they're on TRT for the foreseeable future, so be it, to live the life that they want to live, or if that means there's some ways that, TRT, as well as some of these other things we talked about, can kind of give them that boost that they need, and maybe find a happy balance, that can happen as well. But, it all just depends. I had a patient just recently that phenomenal shape, early 40s, and everything was good, generally good with his numbers besides his signaling, but he wasn't responding to the signaling. So it was just, that just told us, like, hey, we tried that, so we did take our time with it. We tried it, but then after starting a very low dose of testosterone, just was feeling amazing. And there was actually still some meat on the bone for his numbers, technically, from a physiological standpoint. Like, he could even go higher if he wanted to, but it was like, hey, if you're good right here, like, let's just keep you there. You can always add a little more. You have a little room there, but why? What's really the point here? And so then we started to work on sleep quality and a few other things in that around his general health, because he's just a high performing executive and fitness enthusiast, and was just blown away at how low his testosterone was. There's nothing from his lifestyle that would have made me think he had low testosterone, or frankly, the way he looks on the outside. Like, we think like this, muscular guy or manly looking man has got to have high testosterone. No, it was in the toilet, and it was signaling, so it's really interesting when you get in there and just take a look. People do know how to do this.
Let me interrupt the show just for a few minutes, because I want to tell you about one of our sponsors, Evolve telemed. One of the questions I get all of the time, one of the services that you are asking me for constantly is hormone replacement therapy. Women going through menopause, women going through perimenopause, women in postmenopause, women under stressful situations who are dealing with low sex hormone levels, estrogen and progesterone, are constantly asking me about progesterone therapy or estrogen and progesterone therapy. And men, same thing, constantly asking me about testosterone replacement therapy. Plenty of you, many of you, always asking, Jade, can you prescribe me hormones? I need testosterone if you're a man, or I need estrogen and progesterone or testosterone if you're a woman. And I always have to say that I am no longer seeing patients in this way because my educational duties are keeping me so busy. And this is where Evolve Telemed comes in. I have been looking for a company that does bioidentical hormone replacement therapy, and that is critically important. If you're going to be doing HRT or TRT, HRT being hormone replacement therapy for women, TRT being testosterone replacement therapy for men, if you are going to do these therapies, you want the bioidentical hormones. You want the hormones that your body makes naturally, that your body can recognize, that is no different from the hormones your body would make if you were making adequate levels. Bioidentical hormone replacement therapy does just this. And Evolve Telemed is a company that I am now using for my own testosterone replacement needs and have been super impressed with the way that they have structured their business model. And so I am now bringing this service to you through my partnership with Evolve Telemed. Essentially, the way this works is you go online, you make an appointment with Evolve. Evolve gets a doctor with you on a Zoom call. They go through your whole case. They go through your blood labs. They then prescribe your hormones directly to you, and you can get those hormones wherever you are. You do not have to go to a clinic near you. All you need is to have an internet access point, and you can meet with an expert in bioidentical hormone replacement therapy and get those prescriptions. Now you can see why this is so powerful, can't you? Because this is something that so many of us need and can benefit from for our aging needs, our sexual health needs. These things have profound impact on mood, hair, skin, erections, libido, you name it. These things do everything for our metabolic health and vitality. So I am incredibly excited to bring Evolve Telemed to you. Now, the link that you go to is drjade.com/hormones. drjade.com/hormones. This will bring you to the Evolve Telemed portal. If you use the code NEXTLEVEL, you will get a discount on checkout for your first patient visit. I'm very excited to be able to bring this to you, and I hope you will use Evolve Telemed. I know you're going to find it extremely powerful to move your hormone needs over to them. Check them out, Evolve Telemed. Use the link drjade.com/hormones. drjade.com/hormones for Evolve Telemed. And let's get back to the show. And you know what? Joe's been bringing up, for everyone listening, he's been bringing up something that we should point out that a lot of people don't know. You've heard Joe say a couple times, drive, mental drive. This is one of the things that I have also seen, and that most of us would work in this space. It's not just, a lot of people think libido, erectile issues, that kind of thing. It's a lot of it has to do with high performance, this drive, this ability to focus, this ability to feel like I want to win again, and I'm engaged, and I have a competitive drive. It's one of the first things that I think of when you start seeing someone who's just lethargic, fatigued. They call it depression in a man, and it can be, but oftentimes men will call depression lack of that winning drive, when it's not true depression in that. It's just that they're used to having that competitive drive, and it is now gone. And Joe has made note of that several times. So those of you listening, understand this is one of the key things. There are receptors all over the body for these sex steroids, and in the brain is really really important. So let's go through a couple things here, Joe. So let's say we get to the point where, we are going to go treatment with someone. So what are you all recommending normally, right? So we have patches, creams, things like that. We have injection. I know from my perspective, clinically, I always just went injection because I didn't get good results from the creams and patches and things like that. So I always just went right to the injectables, and I usually used cypionate or enanthate. If I had an opportunity to get propionate, I probably would have because I like that better. But there's more injections associated with that. But how do you all sort of manage this with? Because there are a certain amount of people. First thing they're going to say, right? They're going to be like, Jade, Joe, I don't want to inject myself, right? Like this is a big issue with sort of a lot of men. So I'm just wondering how you all handle that.
Yeah, no, I appreciate that. It's definitely something to talk through. As a high level overview, I kind of walk through men and women. Generally what we do is look at injection. There's two different ways that we'll look at that for two different reasons. And then there's creams that we use. And so I would say, when you're looking at men, pros and cons of cream, that we see is, obviously the cream you don't have to inject, but I'll talk about the second way we inject, which is kind of almost like not injecting. But the creams do work, but a small percentage of our men kind of tend to stick with that. The pros of it is if you have to adjust your dosage, it's like the next day you can just change it, right? So it's really not that problematic from that respect. I think a couple things is application. Is it rubbing off, absorption, things of that nature, to where, so it can be a little skewed. And then sometimes it's kind of challenging as a clinician to get accurate labs. So, I would say if someone is doing creams, it's probably recommended to do much more lab testing than what we do if they're seeing changes in how they're feeling, because it may not be as consistent week to week as you can be with injectables. So that's kind of the cream side, a small percentage for men. Women, we do injectable and cream, and I'll just kind of stay on cream first for a moment. But the cream for women generally is a little bit more effective, again, because they need much smaller dosage than men. And so it's nice to kind of control that with women. And some of their side effects may be a little bit more immediate, if you will. If they feel a little something, they're going to be a little more sensitive to that, just because their testosterone as a total versus a man is less. But so we do use cream in women and injectable, and I'll kind of talk about why we lean still towards in women injectable, but a higher percentage are doing creams versus injectable with women, and that might just be the needle part with women. I know some that they just said, I don't care. I'm just going to stick with the cream. When we look at injectable, generally we're looking at what we found with those longer esters, like your cypionates, 2 injections a week over the course of their treatment protocol, right in that 3 to 4 days. That's going to eliminate a lot of peaks and troughs. And what we mean by that is essentially like when you first take your injection, it's kind of just slowly going down. And then at the bottom of that, you're going to kind of start to feel some of those low testosterone feelings again. And then we're going to, put it back up and shoot you up high. Again, when you're high, you're more likely or more susceptible to those side effects that none of us want. Generally, therapeutic dosages, you're not going to see them, but if you're someone more prone to them, some of those spikes, you're going to do that. That's why we don't touch patches either, or just generally in my experiences, and what I've seen out there, I would try to steer away, maybe steer a little bit more away from like the pellets or patches, things that are not as controllable. With injections, that's very clean. It's the exact same dosage you can do. And there's 2 different schools of thoughts on injectables kind of once we get into the administration technique. So just to back up, twice a week, kind of, again, it keeps it more of a steady throughout their treatment. And then also what's really important is to make sure you're working with someone on when your lab draws are being done, because we've had it doesn't necessarily matter when you get them done, as long as it's consistent and when it was done. So if I say, Dr. Jade, was this like the morning of your shot? Was this the next day, or was it a week later? That's going to determine how we prescribe. Because if I'm a doc and I see it and I say, all right, well, hey, you barely went up. Like, we need to give you more. And you don't think to ask that question back to the doc. Well, now you're going to be overloaded on testosterone and maybe, get some things that you don't want to get out of that. So that's what's really important too, is knowing when to do that and just have that be the same. Generally it could be the morning before your next administration. So we know like when is, even though we're doing it twice a week, when is that trough is like our checkpoint, but then every time we do it at the same time. That's key. Same with women in their menstrual cycle. Like we always tend to do it in a certain day. So we just know we're comparing, if you will, apples to apples every time. So we're not just all over the map with their hormones. Now, as far as injectable administration, there's two schools of thoughts out there. I've worked with clinicians that are passionate on both, sub-Q and then muscular, right? So muscular is going to be the more invasive. It's going to be a larger, needle. It's going to be maybe a little bit more uncomfortable for people. However, the volume you can deliver is a little bit easier. It's a faster process as far as your draw and delivery of it. And then from a physiological standpoint, people that are pro that type of method, they both work, but that are lean towards that method is state that in the muscle tissue deeper in there's just more blood vessels that can kind of grab onto those hormones and things and just put them into use in the body. So that's kind of one school of thought that's out there. I also see other prescribers that are really heavy and they're very adamant on subcutaneous. They just believe strongly in that administration. I think patients like that one more because it's a very small pin that you're using. It's like a little prick. You barely feel it when it goes in, and you're not, having to go really deep into the muscle tissue. And the downside to that is it does take a long time to draw. And also as you're doing it, you're kind of, holding the pin a little bit longer because it's a very, very, very small needle. So it's going to come out slower versus like a muscular. But the benefits of subcutaneous in a lot of the fat cells, there's less blood vessels there. So one of the, there are some studies that point to this. Again, there's still some kind of open back and forth, but again, it's not enough, I feel, to where you can definitively say one's bad or one's good. That's not the case here. But where essentially that drip, if you will, or that the usage of that testosterone and the metabolites and how it's metabolized is a little bit slower sub-Q. And so it kind of helps eliminate some of those peaks and troughs for that patient. So, those are some things to consider and to talk to your prescriber about, but there are different methods there. And that generally will guide on adherence. Like what are they willing to do? How they feel in their follow-up labs and the benefits, and then your prescriber and their reasoning and rationale behind why they want you to do it a certain way. And then there's another level where we actually do test metabolites, and we could even get even more accurate and just figure out, well, because of the way you metabolize them, let's do it this way. And we wipe out all the other things I just said. And it's just like, this is just how your body does it. Now, again, they both work very well, generally speaking, across all people. It's just a matter of, how to look at the administration and so forth.
Yeah, and the sub-Q injections give us other sites that we normally don't think about, right around the belly button and stuff like that. I certainly have moved to sub-Q injections myself, but you're right. You're using an insulin needle basically, or something close to that, and it takes some time to draw that out. I'll give you a sort of an interesting aside based on not an aside, but interesting example of what Joe was talking about, everybody. So I remember one of my clients when I first got him on TRT and we remeasured, his numbers were at 1600, higher than I would want them. But not like, up into the 2000s, which you can see, but that was higher than I want them. Normally I'm wanting them right around 1,800 to 1,200 is where I feel comfortable, higher than what I wanted. And one of the things at that time was I did say, when did you take your injection? Right. And waited a week and redid the test, and he was down near 800 at that time. So you will see these fluctuations, and I have made that sort of mistake. So had I not caught that, I probably would have, reduced his amount. What I actually ended up doing, this is, kind of before we were doing the 50 and 50 rather than just a 100 milligram, because it used to just be like give a 100 milligram dose every week. And one of the things I did at that point was say, okay, we're going to do 50 and 50. And that kind of smooths things out. So I just really like that Evolve and you, Joe, are so up on sort of how this stuff works. And it does give you the man or the woman options related to how this is delivered. So you're not in this position where you're like, oh my God, I don't want to inject myself, so I have no options. You actually do have options. And one of the things that Joe is alluding to here, when you use these little small needles in the sub-Q, you don't feel these things at all. And you're not even intimidated by the needle. Really, it's basically the same needle you might use if you're, the old HCG injections. It's just, and I actually use those in all the traditional sites, because even though, the glute is a little bit leaner, or the thigh, it's just not going in as deep, and you're still getting the effects. So let's finish up here in terms of, okay, so what are the things that we need to then look out for once this starts? What do you all like to see in terms of numbers? What are any other things that you want to sort of look at? Because I know there's this sort of debate, sort of in the field, where people just go, don't treat the numbers, treat the symptoms. And, but you kind of do want to look at the numbers as well. And what are you usually looking at there?
Yeah, a lot. There is a lot to look at across the board. I mean, we discussed a little bit of it the last time we connect too, just kind of talking through the benefits of starting treatment versus the risk of starting treatment. But then a lot of times that's where, in the medical community, from what I've gathered, they'll stop, versus adding the third part, which is, the risk of not starting treatment. Right. Mm-hmm. So there's a lot to really consider there. I think overall, when someone's starting, we look first at their risk factors and their health profile before they come in, having a thorough physical on file, getting those initial labs with all of your general health markers, as well as those hormone testing in there. And that'll kind of indicate some things. So while they're on treatment, we're looking at platelets, hemoglobin, hematocrit, seeing, were they already high beforehand, their blood pressure, did we see any change there? Generally speaking, over a long term, you're actually going to see a reduction in there, as long as they're using the testosterone treatment to help fuel other healthy activities. If their activities were poor in general, call it poor sleep, high consumption of alcohol, eating poorly and not exercising, and then just add in testosterone and do more of that because now they have more energy to do those things, then yes, those numbers are going to get worse. Like, there's no question. But to stand back from a 10,000 foot view and say, oh, testosterone caused that, it's like, well, let's call time out there, because if you're starting some healthy activities, generally you're not going to see those changes or to affect where that's going to be problematic for someone. As we're kind of progressing through, you're watching different things as far as prolactin and PSA, just seeing, where were they before we started, and are there any changes based on the compound they're using? There might be a combination of different treatments correlated in with the TRT that could help with things that could affect prolactin potentially, that help with like joint health and things. And so it kind of depends on that standpoint, but we're monitoring that as well. And then lastly, estradiol, anywhere from a score of ballpark 30 to 50 is kind of like, something to aim for, if you will. But again, everyone's generally, people metabolize at different rates. I mean, I've had mine done, and I've had several others done to where, regarding estrogen, if I go a little bit down the rabbit hole here, but that's why, we'll look at that, or a percent of total testosterone, say like 3 to 5% is kind of a general sweet spot. But the one thing I've noticed, this is with women hormones and men hormones, male hormones, estrogen metabolism, has the 3 levels of metabolism there. And a lot of times, a lot of experts in the field that are doing these diagnostic testings, they'll refer to the second phase of metabolism as like the bottom of a sink drain, right? Mm-hmm. And what they'll talk about is, if that sink drain is full and you're basically, the pathways your body's choosing is causing some of those metabolites from those hormones to get backed up, that can kind of back up your whole system to where what you're doing, your actual estrogen levels are in a healthy range, but your ability to push them totally through your body and clear those estrogen metabolites and they're backing up, is actually causing a lot of these estrogen related symptoms. When it's not, it is, but it isn't necessarily the estrogen. It's the fact that the estrogen's stuck there. Think of like a traffic jam. It's not like the guy in front of you didn't cause, it's just because there's so many of you on the road is why you're stuck in this traffic jam, right? It's the same thing with estrogen. And I think that goes to the next level, which is why looking at things like microbiome, gut health, and testing macronutrients and all these healthy lifestyle things is, a lot of people hear us say that and they say, oh yeah, well, you guys are fit, so that's why you say that, right? It's because you and I know are pretty active guys, and it's like, well, one, like we sometimes we don't want to do that also, right? But two, if those things are an issue, you're going to see benefits from treatment. Like, that's not open for debate. Like, everyone agrees to that, but the level of benefits will be affected based on how all those other processes are in your body. And so that's why it's like, if I'm talking to someone, I'm not lecturing you on drinking or smoking or not exercising. I'm just letting you know, like, this is scientific fact. There is no debating. This is how they affect you in the body. And this is how it'll really blunt what we're doing. The whole reason why we're doing this treatment, you're going to get 50% out of it. Like, wouldn't you want to get even 80 or 90, let alone 100, right? Other benefits. So that's kind of just an overview of some things that we're looking at and monitoring. One point I wanted to bring up in that also early on in treatment, you mentioned earlier talking about receptors. And there's, I haven't found a black and white definitive study on this, but I've seen some in the medical literature that they're kind of looking at this, but they talk about these androgen receptors, right? And so this is going to be my way of simplifying it for it as a non-clinician, but I'll just kind of give you a general analogy as, we have all these receptors in our body. We've been low T for say 5 years, right? As a male, women, men, whatever. And now we're saturated with the testosterone. It's actually what we need, but we're saturated relative to what our body's been used to, or these receptors are super, super sensitive and they've been waiting for it, right? Or they're just free. And there's an overload sometimes at that point. So your testosterone is still at the same level. But what I found from some people is there's a little bit of an overload at a cellular level, but more importantly, psychologically, they're not used to this drive, this energy, this passion that they now have. And they have to kind of adjust their psyche a little to that first 4 to 6 weeks. And so I always try to suggest to people like, hey, maybe you're fine and you just feel great, but maybe you feel a little bit more like a little too much amp, almost like if someone who has too much caffeine and they normally wouldn't raise their voice at someone and they raise their voice, right? That we're not talking about, roid rage or some kind of overly, overemphasized aggression here. I'm just saying something for people to be mindful of is that's why that retest after you're on treatment for about 6 weeks or so is so important, and having working with a practice that communicates with you. So A, they can either put you at ease, or B, let you know ahead of time of what to expect, because I did notice that in some patients to where they were just like ready to take on the world. And then it kind of steadied out, not in a bad way. Just, it was a little over indexed because the body, the mind was so not used to having what it needs. It was just like, almost like go time a little too hard, which can lead someone down. I'm not a psychologist by any stretch of the imagination, but it can lean down to maybe some more risk taking or risky behavior early on in cleaning up some of these hormones too. So it's just good to kind of think of that as a whole picture and look at that across the board. So I just thought I would put that out there as well when someone's starting.
And I'll add a few other things here for my final thoughts on this as well. So one of the things I've seen as a clinician is a lot of men will go on TRT or seek TRT due to erectile issues. And so one of the things that can happen, almost always, it fixes those things and that gets much better. However, there are times when you start TRT, especially at the higher doses, that you will see erectile stuff that you didn't have start to crop up. That's almost always, as Joe was pointing out, related to this estrogen sort of situation. So Evolve is looking at this. I certainly would be looking at this as well. So you want to pay close attention to that. Also, men with sleep apnea can have issues when they go on TRT. It can make that a little bit worse for those individuals. One clinical pearl here with the androgen receptors is there's a relatively cheap option, acetyl L-carnitine, that sensitizes the androgen receptors. I have certainly used that and noticed the difference. It's an N of 1 in myself. I can't say I've used that in a bunch of patients. And even if I did, it would be difficult to tell, when you give a supplement like that. But there is some interesting research on that. I have personally seen that helps smooth out the effects, the brain effects. I feel good on acetyl L-carnitine even without the testosterone. But that's another sort of thing to look at. But some of these things, it's important to understand when you're looking at TRT, and it's what I love about Evolve, and whether you're a woman as well, right, or a man who's seeking these treatments, you need to just have someone who is aware of some of these things, because while you'll see most of the time all this stuff get better, you may see some of these things get a little worse. This does not mean you shouldn't be taking the therapy. It still can be highly beneficial for you. It may just mean you're pushing certain pathways that the clinician on the other side needs to pay attention to. That's why I love what you were saying, Joe, about the estrogen metabolites, and looking at phase 1, phase 2, phase 3 detoxification as it pertains to estrogen. This is a pretty big deal and can make a big difference in terms of how this treatment is effective for you. And this is what I want you all to sort of understand why I love Evolve and what they're doing, because they're looking at this in a very deep level. They're not just going, oh, you've got low testosterone, let's give you, testosterone therapies. They're doing this in the way that I would be doing it in my clinic as well. And they're doing it with a large number of patients. And you can learn a lot when you have a big clinical database like that. So, Joe, any final things? I really appreciate your time, man. You're just a wealth of knowledge on this. I know you know a lot about peptide therapy as well. So I was talking to Joe before we started. I'm going to try to get him to come back on the show to talk peptides with all of you, because that's not something that I am that well versed in. As you can tell, Joe has a lot of expertise in these areas, and I would love to learn from you about peptides. But is there any final thoughts here about testosterone, anything else you want us to know? And make sure you tell people where they can find you. Obviously, Joe is representing Evolve right now, so we go over to Evolve. They're at Evolve Telemed on social media. But tell them where they can find you and Evolve, or any other details you want to give them.
Yeah, sure. EvolveTelemed.com. There's a really simple intake form there. There's a phone call. There's an email. It's not a high pressure, sales type scenario. You can just kind of poke around, ask some questions, and the team will be happy to help you out there. If you reach out to me, I also have links to Evolve. I'm Joe_M_Miller, I think, on Instagram, and just pretty much Joe Miller across the board out there. Pretty easy name not to forget through all the social media channels. But yeah, it's a pleasure to come on and talk about it. I think, I think, as I mentioned, the main thing is just testing and assessing, doing the diagnostic work to know where you are, and then working along that process, and make sure you have an interactive process with whoever your provider is, so that you can stay on top of your health and be proactive with it and really get the most out of the amazing benefits of these therapies and treatments that are available to you.
Yeah, I appreciate you, brother. Thank you for the wealth of knowledge, and I'll see you on a podcast soon.
All right. Take care. Bye-bye.